Assalamu alaikum, it's me Dr. Naseem Shirzad, and today I am going to discuss with you all the vasography, the indication of the vasography, and the technique of vasography and interpretation of the finding. There are three absolute indications for vasography, and all these three findings must be present before going for a vasography. Number first, the presence of azoospermia. Number second, there must be a complete spermatogenesis with many mature spermatid and testy biopsy, and at least one palpable vase. These three must be present before going into vasography. There are some relative indications for vasography, which include severe oligospermia with normal testy biopsy, high level of sperm bounded antibody which indicate unilateral, bilateral, or partial obstruction, low semen volume, and very poor sperm quality, which showing partial ejaculated duct obstruction. And the most important is that vasography should answer the following question at the end of procedure: Are there, are there is any presence of sperm in the vasal fluid? Is there is any obstruction in the vase? So these answers should be present at the end of vasography. One thing which is very important, that there is no need to perform vasography at the time of testy biopsy for azoospermia unless if you are having no plan of immediate reconstruction and the touch wet prep biopsy reveal the mature sperm with tails. So in this condition, when you have no plan to perform reconstruction, there is no need to go for vasography at the time of testicular biopsy. Now, the technique for vasography and interpretation of finding include if a patient is having inguinal hernia repair, particularly when performed in childhood, is known to be associated with basal injury leading to obstruction. Now, if there is no previous inguinal incision and the site of obstruction is unknown, the test is delivered through a high vertical scrotal incision. So, if there is a hernia repair and you have clear cut scar, so go and give incision at that area and take the was from that area. If there is no scar mark or you are not sure about the site of obstruction, so better to give a high scrotal incision. The was difference is identified and isolated at the junction of the straight and convoluted portion of the was difference. Then at this moment use an operating microscope of 10 power magnification. The vessel sheath is longitudinally incised and the vessels containing like the vessel should be carefully preserved. Then a clean segment of bare vase is delivered and surrounded with the vessel loops. Again a straight clamp is placed beneath the vase to act as a platform. Now under 25 power magnification, a 5-degree micro knife is used to hemi-transect the vase until the lumen is revealed. So now after opening the lumen with the 15-degree micro knife, the fluid, any fluid which is coming from the lumen is placed on a slide, and that is mixed with a drop of saline and sealed with cover slip for microscopic examination. Now if the vasal fluid is devoid of any sperm, means there is no sperm in fluid. With repeated sampling even after milking the epididymis and convoluted tubules, means from the testicular end, when you start milking and there is no fluid coming, it means there is obstruction on the testicular end, means the obstruction is present at the epididymis. So this was for the testicular end. If there is no sperm coming, it means no fluid coming, it means there is a epididymal obstruction. Now coming to the seminal vesicle end. The end of the vase which is toward the seminal vesicle, we cannulate that area with 24 gauge angiocatheter sheath and we inject around 1 ml of ringer lactate solution with 1 ml tuberculin syringe. We confirm the patency. If the ringer passes easily, then there is no need of formal vasography. If further proof of patency of the vase is desired, then you can go for 1 ml of 50% dilute indigo carmine solution, inject that and you will see the blue or green dye in the urine uh, as we have placed the catheter in the bladder. So the indigo carmine diluted 50-50 with Ringer solution is prepared. Don't use methylene blue because even at a very low concentration, methylene blue kills sperms and render them useless for cryopreservation for immediate IVF or intra-cervical or intrauterine insemination. As on opening the vows, if there is any sperm found on that, better to preserve that for future use. Now, the scenario if the motile sperm are found in the vase, the testicular end should be gently. If you found any sperm and you are thinking that the testicular end means the epididymis is opened, so better to barbotage that with 0.2 ml of human tubulant fluid media and the fluid processed by the andrology laboratory for sperm preservation for potential future use. This should be done before injection with indigo carmine or X-ray contrast material. Now another scenario, if there is a large amount of fluid after opening the vase and that are just like a crank keys or oily appearance, it means that the obstruction is toward the seminal vesicle end of the vase. In this case, the vase is usually markedly dilated and a 2,0 proline suture be passed toward, like if found that there is some very thick fluid is coming, it means there is some problem toward the seminal vesicle side. So pass a 2,0 proline suture toward the seminal vesicle end of the vase and clamp placed on the proline. And if the obstruction is proximal to the inguinal scar, a formal vasography is performed by passing a number 3 urethral catheter toward the seminal vesicle end of the vase. A 6 pulley catheter is placed in the bladder and the balloon is fed with 5 ml of air. Placing the balloon on gentle traction before vasography prevent the reflux of contrast into the bladder, which can obscure detail. The air-fed balloon also identifies the location of the bladder neck relative to any obstruction. So now after the vase has been cannulated, vasogram are performed with the injection of 0.5 ml of water-soluble contrast media. If vasography reveal obstruction at the site of ejaculatory duct, indigo carmine or after sperm has been aspirated and cryopreserved, methylene blue is injected in both vases to facilitate a transurethral resection of the ejaculatory duct. Now the two scenario can come. If both vases are visualized after injection of the contrast into only one vase, it means that both vases emptying into a single cavity, usually a midline ejaculatory duct cyst. So it is important if you inject into single vase and that cause the visualization of the both vase, it means that it emptying into a single cavity, usually a midline ejaculatory duct cyst. Now coming another scenario, if the vasography reveal the vase difference ending blindly, so it means that the finding indicate the congenital partial absence of the vase difference, and in these patients should be tested for cystic fibrosis mutation. So at the end of procedure, the hemi-transected vasography site are carefully closed microsurgically using 2 or 3 interrupted 10-0 monofilament nylon suture for the mucosa and 9-0 for the muscularis and adventitium. The two important things, if the vasal fluid reveal no sperm and vasography confirm patency of the seminal vesicle end of the vase, it means there is some obstruction, so better to go for the vasoepididymostomy. Now if the vasal fluid reveal many sperm and vasography normal, then there is either retrograde ejaculation, lack of emission, or aperostosis of the vase.